Firstly, I am pleased to introduce Deborah Tegere, the country representative for CBM Zimbabwe, to give an introduction to some of these barriers that women face accessing eye health services in the Africa region. So, Deborah, over to you.
Thank you, Susan. Yes, my name is Deborah. I'm based in Zimbabwe. I'm just going to give a very general overview of some of the main barriers women and girls accessing health services in the region. I hope my presentation will not be biased towards women only, given that gender is about both men and women. But basically, gender refers to the socially constructed characteristics of women and men, such as norms, roles, and relationships and between groups of women and men. It really varies from society to society and does change. You'll find that gender also relates to socially constructed characteristics and looking at how men
sorry, Deborah, just to jump in a second, we're losing you a little bit on the sound. I don't know if there's a little bit of a problem with the speaker, or if you could maybe go a little bit closer to the speaker on your microphone.
Sort of fading in and out. I don't know whether it sounds better.
Yeah, that's better.
Okay,
yeah.
Wonderful.
Thank you.
All right, so I was saying that by basically looking at gender, we're looking at the socially constructed characteristics of both men and women and how they interact with the society. Now, over the past few decades, it has been seen that more men than women have been accessing health services, in particular, eye health services. Why has this been the case? You'll find that men have been are the head of the home, and by that, they usually make decisions of their well-being. Women lack financial autonomy and hence wait for their husbands or spouses to approve or provide resources. In most cases, women have also resorted to other alternatives because they are not financially stable. You'll find that women can even use the juice of tomatoes as a short-term solution, but that can also lead to blindness. Now, culturally, women are supposed to conform to the society in terms of the man being the head, and this is a sign of respect. Women do give birth and are exposed to tremendous pain, and in most cases, women have had to endure eye conditions that could lead to blindness. The role of women in society or communities, for example, their social responsibility, family responsibility, the aspect of household chores, often very hectic and prioritized. Hence, this has hindered their access to eye health services. In some cases, they are required to travel long distances to access these services, either to the nearest health center, which may not be very near. And in some cases, they've had to also carry their babies on their back, hence affecting access to services, as they find this very hectic. For example, in Zimbabwe, eye health has not been prioritized in the expanded immunization programs. This is where most women and children are involved, and they often comply to immunization programs. But the fact that eye health has not been prioritized and included in this expanded immunization programs entails that this has been overlooked and has affected access to eye health services by women. But given the recent experiences that we've had over the past 5 years, here I would also relate to the Seeing is Believing project that we have been implementing in Zimbabwe since 2015 as one of the Vision 2020 programs. You'll find that there has been an increase in the number of women accessing services or eye health services as compared to men, although the margin is not very huge. What has influenced this increase? Mainly, it has been the positive health-seeking behavior as a result of awareness programs. There's also been a lot of key messages going out to different communities promoting access to health services by women, including women with disabilities, because we have also been considering the double discrimination. You'll find that over the past few years, a number of women have also been heading households, mainly because either they are single mothers or their spouses are working in town or in the diaspora, hence they can make decisions to access these services. More and more women are becoming empowered through other community empowerment programs, which has led to financial stability as well as increase in their knowledge on health and in particular eye health. Most village health workers trained are women. And you'll find that these have the ability to influence other women. And this has also been very influential in our project. And the fact that most of these women have hectic schedules, we have also tried to reach out to these women through outreach by bringing the eye health services closer to the community. And these have often been free or subsidized in order to promote the increase of access to services by women. Thank you.
Thank you so much, Deborah, for that really interesting overview. Really appreciate you going into some of those, those specific reasons why maybe with some of our Seeing is Believing projects or eye health programs in general, you may find that women aren't accessing services at the same rate as men, or as you would be expecting the numbers to be, which would even be slightly higher than men. Okay, so thank you, Deborah, for that. Right, so just a quick update on where we are with how many people are on the line. We've now got 26 attendees, which is absolutely fantastic. So welcome to all of you. And I can see a few people have introduced themselves in the chat box. So, for example, we've got Charity from Sight Savers UK. We've got Kirale Kunuk from Orbis Africa. And we've got Emma Davies from here in IPB London. So welcome to all of you. And if you want to ask questions at any point for any of our presenters, then you can type them in your chat box, and then we'll do question and answer at the end session. So firstly, for our presentations, let me introduce Godfrey Kagwa, from Brian Holden Vision Institute, who was the project coordinator for the Child Eye Health project there. So Godfrey, over to you.
Thank you, Susan. Like I've been introduced, my name is Godfrey Kagwa. I work for Brian Holden Vision Institute. I'm here to present this evening or this afternoon gender issues related to the just concluded East Africa Child Health Project and looking at the Uganda perspective. Can we have the next slide, please? This project, as you'll see in the next slide, was implemented across 3 East African countries, that is Tanzania, Kenya, and Uganda, as labeled by numbers 1, 2, and 3. But the areas where the project was implemented is identified by the arrows as seen on the maps. In the area number 4, it's just an indicator. It just shows us the partners that were involved in the project. These were 8, and I must say that gender was well observed because we had more women than males in the consortium that implemented the project across East Africa. Next, please. Before we tackle the real issue of gender, we need to be informed that in Uganda we have a gender policy, and in the gender policy, several barriers were identified that limit access to health services for women and girls. These include long distances to health services, Then the other one was is higher level of literacy among female than males, and this of course limits overall emancipation that we are looking at. Then the other one is higher level of poverty among women and girls. This of course limits purchasing power for the key health services. We also have some famous or infamous campaigns which are gender unresponsive campaigns. For example, we have the Ministry of Health campaign known as Go Together, Not Together, which requires men to accompany their wives for services. And this, of course, means women use of services in case men are not responsive. In this campaign, women, for example, going for reproductive health services, antenatal services, and the rest are encouraged to go with their husbands so as to have that bit of boost in terms of men involvement in women health issues. But in this case, if men don't respond, this limits women services. And that, of course, becomes a barrier. Now, as a project, can we have the next slide, please? And as a project was being implemented, we had some gender project services strategies that were implemented or observed, and I can give a summary in this slide. For example, in the area of human resource development, gender sensitivity and balance was highly observed. At the end of it all, about 50 males and females were trained in this area. And when we look at school screening and health service delivery, again, gender balance was observed. And here, as we shall see later, more girls were screened than boys in the schools. And when it comes to health services, again, more female attended health services than males. During project designing, implementation, monitoring, women were more involved alongside the project activities. And during data collection, our data was segregated by gender, as of course it is in the National Health Management System. And one of our partners, that is Ministry of Gender, Labour and Social Development, provided technical gender-related guidance and monitoring. This is the government ministry, but this is the custodian of gender issues and monitors and guides issues on gender. So we brought them on board to help us during the implementation process. Next slide. Now, like I said, during human resource development, in areas of school teacher training of clinic officers or like care health workers, we also trained communities, these are very health teams, and other general health workers, the nurses and midwives, as well as children themselves. These are the vision champions. We had almost 50 to 50%, as you can see in the slide, males and females. Next slide, please. And in terms of service delivery, these are in the areas of school screening, service delivery, and health education and promotion. The cut-off age bracket for the children was 15 years. So we went to schools, trained, and had a screening activities done. In service deliveries were basically at the health facilities, and these were more medical related other than surgery. Our consortium was handling primary level activities, basically screening, but also on identifying, but then referring cases requiring surgery to tertiary, which was handled by another consortium headed by SiB. Cut-off age bracket for a child was less than 15 years. And in the area of health education and promotion, you can also see that the totals indicate that more females were attended to than males. Next slide, please. We also know that in order to intensify emancipation, we need to involve women as agents of change. And we all know a nation. That's a famous saying. And picture one, it indicates a nurse talking to mothers who had brought children less than 5 years to go and conduct health education messages and services to patients who have come to for medical health services. And here immunization clinics, children under 5 years were targeted and were being educated. And so that the mothers were being educated and reached. And in terms of reaching access, that is around picture number 2. The project established 4 well-equipped eye clinics in the remote parts of the country, 3 of which were headed by female and 1 was headed by a male. And in terms of improving policymakers, our government is very sensitive about gender, and it has also involved women at that level of policy making. In the picture number 2, you can see our Minister of Health, who's a female, opening one of the clinics together with a male, and the male is none other than the outgoing Chief Executive Officer of Standard Chartered Bank in Uganda. Can we have the next slide? We experienced several challenges, but also managed to make some innovations towards solutions to increase appetite. Among the biggest challenges was failure by the parents of the referred children who had been screened and referred to health services. To referral centers due to this, but I must say that the project didn't experience all the barriers, because some of the barriers are, for example, related to surgery. These are, for example, fear and cost, which we actually never experienced. But some of those we experienced are distance, poverty, and ignorance. And as a solution, and went out to reach those who were unable to come for health service.
Oh, hello, Godfrey. I think we're losing you a bit now. Hello? Oh, the line's gone really bad, actually. Oh, I can hear you again now. Yeah, sorry, we lost you for a little bit there, but sounds like you're. Hello?
Hello?
Ah, yes, you're back now. Sorry, Susan here. We lost you for a little bit there, but sorry, please continue. Yeah, with your challenges and solutions.
One of them was, of course, failure by the parents of the referred children to escort them to referral centers due to distance, poverty, and ignorance have alluded to this, and we brought in an innovation of conducting outreaches to those children at specific areas as identified by the project managers in the district. We also strengthened the community mobilization and sensitization using IEC posters that we printed out and owned by government itself, and also we use radio talks as well as community health workers who went out to reach the members of the communities. Then in terms of access,
Hello, Godfrey?
especially towards the blind and visually impaired children. Hello?
Hello, sorry, the line cut out again, sorry, please,
Hello?
but I think you're back now, so please continue.
Yeah, we conducted special eye care outreach programs to schools for children with disabilities. Am I clear?
Yes, yes, we have you.
Hello?
You're clear now, thank you. Yeah, we can hear you.
Okay, we also used the community health workers who mobilized the non-school goers out there in the communities. Then we made an innovation, we suggested an innovation of forming small parents associations of mothers and parents of children who were blind, who would go out and mobilize others not yet reached. We also had issues, challenges related to advocacy. So we developed a collaborative advocacy strategy for eye health, which was developed jointly with the Ministries of Health, Education, Gender, Labor, and Social Development. This policy strategy has been adopted by government and will go a long way to advocate for eye care health services, of course, gender inclusive. Can we have the next slide? And along the way, we had some lessons to learn. And among the lessons to learn include lack of a smooth, well-coordinated collaboration between stakeholders and, of course, a clear understanding of the country gender regulations can impede attainment of gender-related concerns. And the other lesson we learned was that more girls and boys are reached when services are brought closer to them. If you don't move nearer to them, you will not attain or will not actually get the numbers required. And the other one was that majority, that is about 60% of the blind and severely low vision children are not in school in our country. This was as a result of a childhood blindness study that was conducted in Tungamo district, again through the support of the SiB project. Then the other was that neither children by gender are easily reached with the involvement of families, communities, schools, religious institutions, media, political leaders, peer groups, name them. And that project data indicated that girls were accessing health services more than boys. This is very interesting, but because even just recently, as I was listening to the radio, UBOS, that is Uganda Bureau of Statistics in Uganda, made a study survey and found that more girls in the country were actually accessing education more than the boys. I think it's because of the peaceful policies. And then finally, next slide. The project was gender responsive as self-assessed by the gender assessment tool. This tool, of course, was developed by WHO and whose cover page is on the right of the slide. This is a useful document which, if one read through, can guide projects, project implementation as far as gender issues are concerned. Thank you very much for your attention.
Excellent. Thank you, Godfrey, for that insightful presentation. And what's interesting is that this project has been focusing on getting both boys and girls to access services at the primary level, where there appear to be less challenges for some of the reasons that Godfrey mentioned, moving services closer to the children. So it will be really interesting to compare those findings with that from our next presentation, which has been focusing on reaching the primary and secondary services for women and men. So I think that's something to be thinking about when we go on to our next presentation. Just as a quick reminder, I can see a couple of people have already started putting questions in the chat box. So if you do have any questions for the presenters, please type them in the chat box and we'll do the question and answer session after our third presentation. So I'm now pleased to introduce Moffat Shawa, the Orbis Project Officer for Northwest Province, Zambia. So Moffat, over to you. I'm just going to quickly change the slides over. So Moffat, please go ahead. I think you might be muted. One moment. I think Moffat, if you can unmute yourself. One moment, please. Click to unmute. Ah, Moffat, I think you should be with us now. So please, Moffat, yeah. Over to you.
Thank you so much. As Susan has mentioned, my name is Moffat Shawa, the project officer for Orbis Africa Northwestern Province. So my main topic of discussion, which I'll share with you this afternoon, is improving women access to eye care. Next. So the overview of the presentation actually looks at three main areas. I'll talk about the gender-focused research that was conducted. Then also talk about the barriers and the picture at the moment of what we've done so far. So for the first 2 years of the project, we noticed as a project a consistent pattern of lower rates as in regard to women accessing cataract surgery services. Of course, this was happening after you book, for example, you book 50 women, only few would come to attend for cataract surgery services, and 3/4 were dropping off. So this trend continued for the first 2 years of the project implementation and part of the third year. So as a project, we had to respond, of course, by conducting a research. So the purpose of the study, the gender study research, was to explore the barriers women face in accessing surgery in Monirunga district. Of course, we picked Monirunga district because this was the district that was most hit when we looked at our data. But of course, the problem was everywhere in the province. So this was conducted in Northwestern Province, of course, picking Monirunga district. So the study was commissioned in response to the data showing consistent pattern of lower rates of surgery uptake, by women. So the findings of the study highlighted too many mechanisms which delayed or prevented women from accessing surgical treatment, delays in high health services, and the second one focused on not accessing cataract surgery. So some of, when we look at this slide that has been shown there, we can see that we have delays in accessing eye health services. Why delays in accessing eye health services by women? Of course, they were first starting with the use of home remedies. This was delaying them. Religious beliefs, thinking that prayer can help them, and some certain rituals can heal their eye problems. And waiting for eye specialists to visit the community, waiting for cataracts to mature. Because what we do here as a project and working with the Ministry of Health is that we do not operate on an immature cataract. We wait for the cataract to mature. So by so doing, women were giving up when they were told that the cataract is not mature. They have to wait until it matures. Then, of course, poor counseling and diagnosis, fear of surgery, and the negative stories. Then on the second part of the barriers that were noticed in the gender study report, we have the issue of cataract surgery service uptake. So the reason why women were dropping off is one, the limited education levels, limited decision making, autonomy in the household, limited financial resources in the household. Then the other part was the travel costs. As you know, women are not financially stable in this province, which is more like a village setup kind of a province. So mostly they depend on men, and of course they do not receive such enough support. So they tend to give up. Next. Okay. So after knowing the barriers, of course, presented in the gender study report, the project, in partnership with the provincial health office and other key stakeholders in the province, we had to conduct a stakeholders meeting to share the gender study report and, of course, get the views from different key stakeholders, and of course find the best way of addressing these barriers that were identified to help our women and also help the community, so that we have a community that have good sight. So some of the strategies that came out were the issues to do, the collaboration with traditional leaders. So this was identified as one key strategy which can help the project and the province together with the provincial health office and the district health offices to address the barriers that were identified. Then the other one was female ambassadors, the use of former cataract patients. Of course, we actually believed that the use of former patients is quite pivotal and key, because these former women patients have actually undergone cataract surgery, and they are best placed, to help out other women, encourage them. Of course, we are using women, former women patients during facilitated film screening. The facilitated film screening, this is a strategy we are using as a project for raising community awareness. So this facilitated film screening is used as a platform by the former patients to address the audience in attendance on the importance of cataract surgery and the eye care. Then in addition to this one, the former women patients, former cataract patients, are used as the counselors to provide counseling to women that have been diagnosed with cataract, to encourage them that, of course, they'll get well and their sight will be restored. Then the other part was on the use of community health workers. So community health workers are trained by the OCOs to provide primary eye care. The OCOs are ophthalmic clinical officers. So community health workers who have been trained in primary eye care, they provide primary eye care to the community, and of course focusing on the women, encouraging women. They also provide counseling to the women that have been diagnosed with the cataract, and of course try to go deeper at household level, talking to the families about the importance of eye care. Then the other part is on the issue of transport support. So the project, in collaboration with the provincial health office and support from the district health offices, of course, are working together to provide transport to cataract patients or women that have been diagnosed with the cataract cases, taken from their respective rural health centers to the district health hospital for cataract surgery. And after the surgery is done, they are taken back to their respective places. Next. So when you see the difference in the numbers as compared to the 2013, 2014 on that chart, then moving to 2015 and the current, should I say the 2016 where we started the implementation. So you can see that in 2016, men versus women in terms of access to cataract surgeries and the eye health services has actually improved. So the interventions that were, of course, employed by the project together with the provincial health office and other key stakeholders have actually worked, and this is what we are doing as a project, and with the help of the provincial health office and other key stakeholders, and it has worked tremendously, and we've seen, women coming on board to access eye health services and cataract surgery services. Next. Thank you so much.
Thank you, Moffat. That was a really insightful overview of the gender strategies that the project is implementing. And what was so interesting to me was that by conducting this specific gender research, the project has been able to discover some of the context-specific reasons why women weren't attending surgery as expected. Like you were saying, that you had your list of patients, but 3/4 of them weren't going for surgery, and that by finding out some of those really specific reasons, you were able to devise a range of strategies to address those, such as you're sort of working with traditional leaders, having female ambassadors, and using community health workers to address those specific concerns. So thank you so much for that. That's really interesting. And thank you to all three of our presentations. They've all given a slightly different overview on the different aspects of encouraging women and girls to access services at the expected rate. So now, listeners, it's sort of over to you, really. We already have quite a few questions for our presenters. So if you do have a question, please can you write it in your chat box, and then what I'll do is I'll address your questions to our presenters. So what I'm going to do is I'll sort of state the first couple of questions, and then yeah, if you keep sending me your questions, then hopefully your question will get asked. But if you do have a question, please do sort of write it so that it can be asked. So first of all, I have a question from Teresa Bard from CBM UK, and she's saying she's interested to hear more. I think this is actually from the second presentation, so Godfrey, but I think Deborah also, you've been working on this aspect as well, but she's asking about she'd like to hear more about how the community health workers mobilise the non-school going children. So Godfrey, do you want to start by answering that question, and then Deborah, it will be over to you. And at the same time, whilst that's happening, Moffat, there's a question for you that you can be thinking about, which is from Coronel Marshall Kemmer, and he's asking about, well, you talked about the transport support that's given to people, women, for travelling for surgery. So I think he wants to know a little bit more about basically who's paying for that transport, and he's asking about and is that something that's going to be sustainable, you know, after seeing Is Believing projects over. So I think if we start with Godfrey, if you can talk about accessing non-school goers, then Deborah, you can say something on that, and then we'll go to Moffat on the transport support given. So Godfrey, if we start with you, please.
Thank you, Susan. Thank you, Teresa. We, as I said, in the human resource development, that slide showing how we developed our human resource people who are involved in the project. Community health workers were part of the group that we trained. And of course, these are known people in the communities. They were identified by members of the communities, by the district. We only gave them a sensitization on eye health and the screening processes. A few basic blinding eye conditions, and we then took them through the screening process. We provided them with a screener, a vision screener. We provided them with this simple small torch, pen light torch, and we requested them. They were already mapped from their villages, so they had to go out and make a program on how they moved out. And by so going, they knew where they needed children. For example, where the blind, the homes, because they have household registers, and yeah, they were able to identify those children and be able to talk to them and also refer them. The other area was to identify, to look at any households, children and screen them, because they had the vision screeners. They were requested to go out to the community and do what I would call random screening, but according to their programs within their catchment area.
Great, thank you. No, that's a really interesting. So sort of you working with the community health workers, getting them to check the household registers and knowing the community helped to get some of those out of school children, doing that kind of convincing them to kind of access services. Great, thank you, Godfrey, for that. Okay, Deborah, do you want to talk a little bit about this? Because I think this is something that's also part of your Seeing is Believing programme, accessing children, reaching those out of school children.
Sure. In the Seeing is Believing project in Zimbabwe, we did train the village health workers on child eye health. We had 3 thematic areas that we trained them on, which we prioritized and we thought were very key. And one of the areas was child eye health. The reasons why children do not access these services, or they access these services at a later stage when they can't even get help. So these are some of the issues that were discussed. And according to our policy in Zimbabwe, children are categorized between 0 to 14 years. So we're looking at the 0 to 5 years, where the mothers are mainly responsible for bringing these children to the hospital. So they were also targeting women to ensure that the women are aware of eye conditions that can affect children, hence the need to bring them to access these services. And then secondly, we look at the other category of 6 to 14 years, most of these who are adolescents, and because these village health workers, by them working in the communities, know most of these households, they know where these children are, and by interacting in these communities, they can even also interact with these children. In some cases, the village.
Oh, hello. Oh, Deborah, I think you've muted there. I'm just going to unmute you. Oh, sorry about that. I think we've just got Deborah's just muted there. So, okay, Deborah, do you want to unmute yourself? Or something's happened there. Okay. Okay. Well, sorry about that. Thank you, Deborah. So, sort of talking there again about community health workers, but also something really interesting there around targeting sort of mothers of children and that education piece to help them bring their children in as well. So great, thank you, Deborah. So I'll just, while I'm sort of sorting out Deborah's microphone issue, I think, shall we move on to Moffat, and you can tell us about the transport support. So there's quite a few questions around who's sort of paying for the transport support and just thinking about how that's sustainable. So Moffat, over to you.
Thank you so much. That's a very good question, and we've been thinking about this as the project, but in terms of who is providing the transport issues. Of course, we are working together with the district health offices, the project and the district health offices, the ones behind the issue of providing transport, of course, putting resources together. But another follow-up question on that is on the issues of sustainability. That is also quite a critical issue to look at, but thank you to Minister of Health that have actually come on board with the new directive that government, of course, through the Minister of Health, is now implementing the issue of taking services closer to the people, which is happening throughout the country. And this one is going to have support from the Minister of Health. So meaning all community work will be supported. So like for the issues of taking patients like on eye health, looking at cataracts, of course we've got the OCOs for example, in all the districts. So what will be happening is that the OCOs need to actually come up with the budget, of course, which will fall in that new transformation agenda that the Minister of Health is looking at, the issues of taking health services closer to the people, comprehensive health services closer to the people. Then another way of ensuring that, of course, there is continuity of services is that as a project, we also participate in the provincial planning and budgeting meetings that take place. So we always try to advocate for the inclusion of such activities in eye health when the districts are doing their, budgeting and planning, so that one is catered for, even though the project comes to an end. Thank you so much.
Thank you. Yes, and actually the Orbis Zambia project have written a really interesting article on that, which is on their IPB website, the Seeing is Believing pages, which is around that process of how they, annually work out when the district planning sessions are doing their budgeting, and then they're at those meetings and they're, talking to people and talking to the decision makers around the importance of getting eye health in those budgetary discussions, which they've been really successful at doing, which is very interesting. So thank you for those answers. Okay, we've got questions coming in thick and fast now. So if you do want to ask a question, please do grab your chance. Right, I've got a question here from Chitengi Mahova, who says, thank you for the presentations. It's got a question around, are the community health workers given any allowances for the work that they're doing? And how do you address the issue of the community health workers moving to programs that are giving them more allowances, as this affects the number of households that the remaining community health workers will cover compared to your plan coverage? So sort of how are you motivating your community health workers? And I think probably all projects are working with community health workers, so I think we'll go through the same order. So if we start with Godfrey, then Deborah, and then Moffat, do you want to answer the question around how you're motivating your community health workers?
Okay.
So Godfrey, if we start with you.
Yeah, thank you, Susan. Thank you, Kitenji. VHTs are established as a national system, community system in the country by government. We only add on and use them as added modules to what we want them to do for us. They've been trained, they've been provided with the basics like registers, etc., that they need in the field. Like I said, we only provided a few items in the vision screening, the torch. We actually give them referral forms too, which they use to refer children to the facilities. But in terms of motivation, by training, they were recruited as volunteers. Physically told straight away that they were volunteers and they were coming to do something on a voluntary basis without pay. Anyone not interested was requested to leave at that point. Many of them, of course, accepted and came willingly to serve the community members. What they only require is appreciation as a major motivation, because motivation is not all about money itself, but can you appreciate, can you work with them, can you guide them, all those are very basic, essential motivators to the DHT members or community health workers, like they generally call it. Additional motivations, of course, include t-shirts, badges, gumboots, or anything that the project can provide. In the project design, we're not able to provide these items, but these are lessons we learned across, which we need to do next time we are to do it. Otherwise, other NGOs, yes, they use them. Others agree to give them a fee, but of course, they are not allowed to give them very fat allowances, which can disorganize their work in the future. Thank you.
Thank you for that. So really sort of, picking people who are really keen to be involved in that as a great strategy. Thank you, Godfrey. Okay, Deborah, over to you.
Health workers and incentivizing was more of lessons learned under the SiB.
Yeah, sorry, Deborah, I couldn't hear you at the very beginning there. Do you want to, start again, please? The sound wasn't so loud.
Okay, can you hear me now?
Yeah, perfect.
Okay, I'm saying, of course, the work of these village health workers has always been done in the spirit of volunteering. In Zimbabwe, the village health workers are provided an allowance which is very small, through a comprehensive national program funded by the UNDP. But however, we have also learned that because these are the same village health workers that are trained on maternal health, male circumcision, they've had to benefit from other programs through receiving T-shirts, and we did not make provision for this under our project. So we did learn something. Also, the fact that training them has also been an incentive for them, and the fact that we also provided small things like stationery, a pen light torch, which is not just going to be used for screening the eye, but also for even lighting in their own home if they need to do something in the dark. So there are some lessons learned, definitely. However, it has been a challenge to really provide these resources given some of the limited budgets that we have. But where they have participated in trainings, we have provided a lunch allowance, a very small lunch allowance, and also given them some transport costs. But my experience is if we could incentivize them with T-shirts, hats, given some of the distances that these people walk, which I've also witnessed, they do a lot of work, and a few incentives would really add value. Thank you.
Okay, thank you, Deborah. So one interesting that you talk about the training as well as, of course, the T-shirts and things, but also the training as being actually that can be quite motivating for people because they're also gaining their skills and their knowledge at the same time, which is quite interesting. These sort of non-financial benefits for them to volunteer. Lovely. Okay, Moffat, because you've been working with volunteers, I think you call them neighbourhood committees as well as the community health workers. So, Moffat, do you want to talk about how you've been working with the community health workers?
Wonderful. I think the two presenters have actually hit it all, but anyway, I will try to, because the picture is just the same with our project. So the neighborhood health committees, the neighborhood health committee is like a body that works closely with the rural health center or rural health centers. So it's from it's a neighborhood health committee that picks the volunteers from the community. So when it comes to working with community health workers, I think my colleagues have actually alluded to many points, but I will say on the part of motivation, of course, it's quite tricky because it's not budgeted for. But the training itself, the trainings that we offer, like in primary eye care, is a motivation. Then the other part is on the recognition of the same community health workers at rural health centers. They need to be recognized by the center in charges. Those health staffs, they need to recognize them, and they feel good when they are recognized, because when they are there, they also feel part and parcel of the community work in improving, the eye health of community members. So when we attach them to rural health centers, they feel appreciated. Then the other part is them being part of the eye care team, being counted as part of the eye care team and helping out. Of course, the other part which we can consider as motivation is on the events like World Sight Day. You call them on board to participate and probably offer T-shirts like my colleagues have alluded to. It's also quite a good motivation. Then also project meetings, like for, when you have meetings like mentorship, you also involve them. Also in community mobilization, when the district OCOs, the ophthalmic clinical officers or ophthalmic nurses, when they are conducting outreach activities, they involve the community health workers to mobilize the community. Of course, just with a small token of appreciation, that works out. But overall, it's voluntary work. That's a belief which is there, and that's the formula we are using, and that's the approach the project is using. Of course, ensuring that we are picking people that have the heart and the passion for serving the community. Thank you so much.
Thank you, Moffat. And I think there's really something quite interesting there about the recognition by the centre in charges and them being part and parcel of all the work that's being done by the eye unit. And as I think from what I've seen in projects, it's also when you feed that data back down the chain so that the community health workers know that yes, this person that I you know, recommended for surgery, I've counselled them and they've actually gone for surgery, and then they can see that person now has gone through the system, and that's fed back to them as well, which leads us on to one of the last questions, which is around data. This is probably your last chance now, so if you do want to ask a question, please do type it in, because we're almost getting to 3 o'clock now, so we need to think about wrapping it up. But if you do have a burning question, please send it. But I will ask the question around data, because there's been quite a few different questions around data, but I think one of them sort of I'll ask from Edwin Maleko, which is around what data collection tools and systems are you using within the project. So I think very sort of briefly, just sort of give us sort of a minute each, if you can just talk very briefly about your data collection tools and systems, so how you're disaggregating and what by gender, but anything else. So again, if we start with Godfrey, then Deborah, then Mafat.
Thank you. The data collection tools are in line with the national health information management system of the country, because we try as much as possible to avoid parallel data collection systems whose data will never be captured into the national system.
Excellent. Yeah, no, that makes absolute sense.
However, in some areas, a few indicators which we need to capture also as a project. So we developed tools to capture specific indicators related to the project, and these were disseminated and sent out to the district focal persons who are partners in the project, and who actually collected this information from health facilities and schools and ABC, and passed on to the project for analysis and interpretation. And the system we used to pass over information was via telephone. From the schools, for example, they were coordinating tutors who were in charge of several schools in the catchment area, whom we provided with airtime, would call various schools to provide the summaries of data of children that screened. This was passed over to the district, and the district passed it over to the district by telephone. That was the system of data collection from schools. From health facilities, again, it was a tool that we passed over to health facilities that was filled and then passed over to the project. But of course, the same data was entered into the national health health information system and passed over to the ministry. Thank you.
Thank you for that. Great. Okay, Deborah, let's move quickly over to you then.
Okay. In Zimbabwe, we have a system, our aligned to the National Health Information System. However, for the purposes of the SiB project, we also developed another tool to track specific indicators where we were not just disaggregating by gender. We have also an interest in disability, so we disaggregate by any forms of disability. In addition to that, given our experience in awareness raising, we've also disaggregating our data by who referred you to access the service. Is it the village health worker? Is it the nurse in the clinic? Who referred you, so that we see. In addition to that, we have the qualitative to look at the quality of surgeries conducted. We have a standard template for that, which has been adapted for all CBM-supported eye units to monitor the quality of cataract surgeries, and this is completed on a quarterly basis by the ophthalmologists. Thank you.
Thank you, and thank you for also bringing up that we're monitoring the quality of surgeries as well, because obviously, you know, a sort of a happy patient is far more likely to refer their friends for surgeries if they've had good quality. So thank you for that, Deborah. Okay, finally over to Mafat.
Okay, thanks so much. In terms of the data tools that we are using, of course, the key one is actually, of course, from the Ministry of Health, which is used throughout the country. So we've also adopted it, but of course we have the performance monitoring tool that we use as a project to collect data. So we are also working with the Ministry of Health in terms of data collection using the health management information system too. So data is collected at community level. We are allowed to collect data at community level, even at district level, and at provincial level. We share with the senior health information officer for the province, Northwestern Province. So in terms of ensuring that the data that we collect is speaking the same language with the HMIS, Health Management Information System too. We work with the district information officers from Ministry of Health. So that's how we do the issues of data collection. But of course, there are other indicators that are not captured in the HMIS. Of course, we capture using our own tool. But I'm glad to mention here that as a project and the other non-government organization dealing with eye care in the country, we convened a meeting with the Ministry of Health, the planning unit team, and those that are vested in the issues of data to ensure that those indicators that are not captured in our tools, not only this SiB project for implemented by Orbis, but other non-government organizations like site savers. So we had to advocate for that, and as I speak now, the HMIS has included those indicators that were not captured at community level or even at district level. So at the moment, we are now at par. Thank you so much.
Excellent, and that's a great what a great point to end on. Thank you, Moffat. That's really great to hear. Lovely. So thank you to our three presentations for the Q&A session feedback, and thank you to everyone who gave their questions. It's great to see you sort of engaging within the with the issues and even some other issues coming up within Seeing is Believing projects. So I'd now like to introduce Sally Crook, the Seeing is Believing Programme Manager for IAPB, for some concluding remarks. So Sally, over to you.
Hi, Susan. Thanks very much. And hello to everybody who's on the call at the moment. Yes, I would agree. A big thank you to our three presenters today, and also for all the participants and the ones who managed to get through with their questions as well. I think this has been a really interesting webinar, and I'm pleased that there is a lot of work going on across Africa to try and address some of the gender issues, because I think we do know that this is an outstanding issue for eye health delivery in many countries. I was kind of wondering how I would sort of wrap up the two presentations, and I think one thing I would like to say is I think it's come across that there is a difference in addressing gender issues, whether you're focused on children or on adults, because obviously for children, both for the in-school and the out-of-school children, there's roughly sort of equal numbers. Children are sort of 50-50, but when you get to adults, and especially to the older adults, it's going to very much depend on the demographics of your particular country, and therefore what you should be aiming for. But I really liked both the presentations in sort of showing that yes, there are lots of challenges, but there are also some solutions that have been worked on, and I must say things like Moffat, your graph at the end showing the really lovely improvement in your surgery sort of percentage of men and women, showing how you can really turn things around within the life of just one project if you really try hard. Godfrey, thanks very much for bringing to our awareness the gender manual for eye health. This is something that's been worked on by almost all the INGOs within IAPB, and I think it is now sort of at the finalization stage. I think it's just waiting for final sign-off. But there are some great things, and I would just say on pages 13 and 14 there are just some really nice little sort of take-home messages, and I'll just run through them very, very quickly. The first one is reach higher, and I think that's come across in, well, particularly in Moffat's presentation, that you know, we're not just looking at equity. We are looking at equity, not equality, and normally there are more older women out there, so there are more women who need access to eye care services. And also we know that across Africa a lot more women have trachoma and, you know, need trichiasis and things, so we know that we should be reaching more women than men in our projects. But that your priorities for tackling gender inequality and inequity will vary from one community to another. It might not even be the same within one region. Certainly urban differences make a huge difference, and I mean, like Godfrey was saying, the issue about who is in school, you know, in some countries it's the boys who drop out earlier, you know, they get pulled back into agricultural work and things, and in other countries it is the girls who drop out earlier. So, you know, it's about who are you looking for and where should you be looking for them. And also for the older women, they're not a homogenous group, so they might have different issues at different stages in their life cycle. And then we can't forget the men. Deborah, I was really pleased you brought that up right at the beginning, because we need to include the men. It's not about depriving the men of access, it's about trying to get the access equitable across men and women. I thought both presentations really brought out, and we actually had some of the questions around how are we ensuring that the services are accessible, which normally means about being community-based, and that's another point that's brought up in the gender manual. The issue about tapping into the expertise of others, I'm going to turn this on this head, because Godfrey, I loved your thing about saying how within the country you found that the awareness of your country gender regulations were actually quite poor, and that you needed to work with people to get everybody up to the right standard and, you know, just get everybody sharing what was meant to be happening in your country. The next issue that is in the list is about disaggregating and analysing data, which again came up in questions at the end. This cannot be overemphasized. If you don't have the data and you don't analyze it, we don't know what's going on. And I would say I would link this back to the paper that I wrote that's on the IPB website on Under Seeing is Believing, which is around the gender demographics and eye care, because it is about you know, what are the demographics in your region. Often looking at national data is still not enough. You need to look at the local data. And it's also about opportunities for women across all the eye health cadres. And I would say, I think the examples that you gave about the community eye health workers or community health workers who are going to also be including eye care in their you know, list of sort of activities they're going to be addressing. It is wonderful if you can prioritize and think about, does it make a difference if you're training women or men, and how are they going to reach out into the community? And I just think there's lots of lovely ideas that have come up today, and thanks very much to all our presenters for sharing them. Thank you. I realise we're running over time now.
No, I know it's sort of I do unfortunately I'd love to sort of stay and chat all afternoon into the evening, because there's such interesting points, but I probably will draw things to an end. But thank you, Sally, that was a really sort of comprehensive summary of some of the key points that have come out, so thank you so much for that. So I'm going to end now, so I'd like to end by thanking our presenters, so Deborah, Godfrey, Moffat and Sally, for their sort of comprehensive presentations and responses to all of our questions. Thank you to my colleague John for all the technical support, and thank you to all of you who have participated. I know that everyone's really busy, and I really appreciate you taking the time out to be part of our SiB learning community. And if you would like to share your own gender strategies with our SiB community, gender is one of the themes for the next Seeing is Believing newsletter, so you are welcome to submit your articles to me by the end of November. And now I just have one final favour. I'm going to email all of you the SiB webinar survey, so I'll just email you a survey using SurveyMonkey, and if you could just take 5 minutes just to complete it, because your support for these webinars makes them possible and your feedback helps us to improve them. So thank you once again for all of you joining, and I hope to see you at future Seeing is Believing webinars. Thank you.
Thank you so much.
Thanks all. Thanks. Bye.
Bye-bye.